Hi, I'm Nabil Kasabani. I'm an associate professor at the University of Pennsylvania in the Department of Anesthesiology and Critical Care Medicine.
So, you probably practiced for a while before you had ultrasound-guided nerve block capabilities.
Not well.
Not that long? Okay. Well, I tried to set the stage anyway.
Okay.
But tell me how having ultrasound-guided nerve block capabilities creates an environment of safety and enables you to practice in a more efficient way that is safer.
Okay, so I would say, if I have to guess, I would say ultrasound has been probably the most difference-making or the most differential invention or technology that came about in the practice of anesthesiology in general and in the practice of regional anesthesia specifically. So ultrasound really has transformed that practice from a lot of it has to be with the individual skill set and the guesswork. So now you're taking something that was really the success rate at best was between 60 and 70% in the best hands of the industry, and now you're making that up to like 90% or even higher. So what ultrasound provided for us is the consistency of our practice, consistency of the nerve blocks. I would actually take that a step further, and I would say this is almost becoming a very reliable technique. The same way that when you give patient intravenous anesthetic and they know that they're going to go to sleep, by the time that I put my needle down on a patient, I know that with a very high likelihood, I would say like 99 to 100%, that my block is going to be working and it's going to be very effective. So what that allowed to do, consistency is very important in the practice of medicine, especially when you deal with other specialties like surgeons, whether different surgical specialty, and also provide the terms of consistency in the expectation on the patient side, and really just gives you a great leverage to talk to the patient and set their expectation where it needs to be.
So this has, how much, to what extent has this proliferated through the profession? Where can you give sort of a timeline where it's come from, where it is now, where you think it's going?
Of course. Yeah, so I came to practice, I would say, in the tail end of the use of the nerve stimulation and the start of really when the ultrasound has started to proliferate in practice. And I can find it really, I don't know how many practices around the country now that will be practicing regional anesthesia without having an ultrasound available. It's become almost like a necessity of the craft. And the example that I can think of, which is going to essentially illustrate your point, is our residents, when resident education. So now when residents rotate with us, starting from year one, when we teach them nerve block and we teach them regional anesthesia, we teach them the anatomy and we teach them the ultrasound. We try every now and then as almost as a treat, okay, that we tell them some perspective that this block can be done. If you did it with nerve stimulation, you should expect 1, 2, 3. But essentially the basis of the education, of the medical education for the practice of regional anesthesia is ultrasound. So this whole new generation that's coming out to practice and the generations to come, okay, is going to be all trained in ultrasound. And also the technology, because of a company like this or another company, the technology is getting relatively not as expensive in the bigger picture of other things. So I think it's becoming more available and more accessible to a lot of practices.
Tell me about the ease of use and how that has evolved over time. You talked about, you talked about experts like you, presumably the 5% that really, are at the top of your craft.
Yeah.
But the ease of use enables others to do it. And so we talked a little bit more about that.
Of course. I would also tell you a personal story about that. When we started practice, I remember that we have a very bulky ultrasound machine that was the size of almost a minibus. And it was very hard to drag that ultrasound machine everywhere. and we had almost like 100 buttons to adjust, okay, with every certain function that has to do with the ultrasound. Right now, like when you look at the ultrasound machine that are available right now, it's almost very user-friendly. You don't have to essentially be very facile with every function. Essentially, you can choose from a drop-down menu for whatever procedure that you do, and the ultrasound is going to self-adjust the setting of the machine to the resolution, to how deep, or the penetration, to essentially adapt to the procedure that you are doing. So I would say, like as of now, they become like very user-friendly, and I guess like the new and upcoming generation, okay, of ultrasound that we started seeing like now, maybe the first or the second generation, is this like pocket guide like ultrasound that can fit into or apply to your mobile phone, or just very small ultrasound that you can take everywhere. And I think this is going to be the next wave of like the ultrasound in practice.
Could you comment a little bit about nerve blocks and patient safety?
Yeah.
And the use of opioids?
Yeah. So in terms of patient safety, I tried to not get very much into your first question when you asked me about the ultrasound and safety, because if you're talking like in terms of the pure evidence-based sense, all right, up until now we don't have an evidence, okay, that will state that the use of ultrasound have actually improved the safety of the nerve blocks over any other modalities, whether it's the paresthesia or the nerve stimulation. At least this is the evidence. This is the clinical trials that we have, and this is the literature that we have. Now, do we find that like true in our practice? I can essentially tell you my own sense, but this is going to be my own words. They are not evidence-based, okay? They are essentially practice and evidence-based, if you would say. I would say yes, as long as you know exactly what you are looking at and what you are looking for, all right? But do we have evidence to support that? Okay, we don't, as of today. So still, like the statement in terms of the safety of the procedure itself, is like pretty much like the same. And I have a couple of reasons in my mind, like why that is. But if your question is pertinent to in terms of the safety and the prevalence of the side effects for some of the other analgesic modalities like the opioids, I would say definitely yes. Okay, but you have to look, in that case, you have to look at the bigger picture. You have to essentially focus beyond the needle tip and the block itself. You have to look in the nerve block as essentially one piece of the puzzle in the big picture of the acute pain management. So, and this is what a lot of us physicians like get caught in. We get caught into the technical aspect of the procedure. I understand, like, if somebody still early in their training or still early in their practice, they're going to be essentially, this is going to be their main focus. But as you essentially become, for lack of better expression, like more seasoned, and you start to look at the bigger picture of the block, and you start to realize that this is just one of the pieces of the puzzle. And you would realize how valuable, okay, that is, especially in the age if we're saying that if you're providing consistent service to that patient. And the example I can think of, some of the examples that we did ourselves in our institution, we did a couple of studies with that in some procedures. For example, something like the shoulder arthroplasty. We actually crafted a pathway for enhanced recovery for shoulder arthroplasty. And the main stem of that enhanced recovery is essentially the nerve blocks. So we do nerve blocks, we put continuous peripheral nerve catheters, and this all done under ultrasound guidance. And our success with that has been very high. And we send people home like with these catheters for like 3 days or even sometimes longer. And we're gonna find like the use of opioids has gone like dramatically down. And even in terms of when we look at the long term, in terms of the opioid refills and when did the patient like stop using opioids, we also have seen a lot of signals that patients who have adequate acute pain control in the first 2 or 3 days after surgery, usually they do better on the long term and even in the prolonged opioid use and how many refills they get like after their procedures.
So you're able to, you've been tracking that?
We've been tracking that, yes. We've been tracking that for a couple of things. Some of this work has been published already and some of this work still like under consideration for publication. And I can tell you, for example, one of the studies that we looked at is the use of nerve blocks as part of a multimodal pathway for shoulder arthroscopy. That work was published only like recently, about a couple of months ago. And right now, like one of the other studies that we did for the shoulder arthroplasty, this is now under consideration for publication. but essentially the signals were pretty consistent. And that work was presented in previous meeting in the American Society of Regional Anesthesia.
So how is this also changing, for example, your workflow?
I'm sorry?
Is there a workflow dimension to this, speed and the ability to
Yes. Okay.
throughput?
Yeah. So it's actually it's an added responsibility to the anesthesiologist. And now we talk like in a meeting like this, we always talk about the natural extension of the role of the anesthesiologist from just their role inside the operating room to their role as a perioperative physician. And this is probably one of the prime examples of that. So rather than just them think about it, if they are just passing gas or they just giving the medicine intraoperative, or if you're talking in the strict sense of regional anesthesia, rather than they are just do the block and they just essentially wash their hands out of it anymore. So now the anesthesiologist is functioning as a preoperative physician, as an acute pain medicine physician, because he essentially is calling the shots and designing these clinical pathways, okay, for patients and for different institutions through collaboration with all other members of the perioperative care team.
So the only last question that I have for you is just, we just want, this is a statement that we'll keep internally, but we have a lot of engineers who sit at their desks, optimizing transducers, things like that, and just some kind of little thing to them saying, hey, you know what you do makes a difference. So, hey,
Pep talk.
yeah, just like a one little thing, like, hey,
Yeah.
I just wanted to do that for them, just because you know what?
Yeah, it actually does. Okay, it doesn't have to be. It does, and I can tell you, we see the difference, especially with the explosion, I would say, of the bunch of the newly described blocks, of the truncal blocks, and these now are coming up as an alternative for the for neuroaxial blocks and for epidurals as a conventional technique. And these blocks are typically like deeper blocks. So when I do these blocks, I'm going to use something of low frequency, right? And I'm aware of a lot of the technology that Sonosite is doing, and that Sonosite is doing, that essentially how to make these deeper blocks, how to be my eyes, okay, if you would say, for these deeper blocks. How can I see something that probably 6 or 7 centimeter deep with the same good quality that I see an inch-scaling block that is only a centimeter or two from the skin. And this is not something that I'm not going to be able to do by myself. I have to rely on the people who are much more smarter than me, on the engineers who would do this and are going to be able to come up with the technology, and just told me you have to push that button to get this picture. How's that?
Very good, thank you.